Okay, let's unpack this.
Mhm.
We are diving into what is, I think, for many people, the classic modern curse, low back pain.
Absolutely.
And we're not just talking about an occasional ache here. We are focusing on recurrence, that awful cycle of feeling better and then boom, the pain comes roaring back.
It's a huge societal burden, and the numbers, I mean, they're just staggering. Most people do feel a lot better after an acute episode.
Right?
The pain and the disability, they usually drop off pretty quickly, maybe within 6 weeks. But that relief, it often doesn't last.
It's the cycle of doom. Our sources show that after recovery, 7 out of 10 people
7 out of 10.
will suffer a recurrence within the next year. I mean, that statistic, it just stops you cold. It really screams for accessible solutions.
It does. We need strategies that aren't invasive, that aren't crazy expensive, and that people can actually stick to.
Which brings us to our mission for today.
Yeah, and we're looking at maybe the simplest activity there is walking and what it can really do.
We're diving deep into a secondary analysis of the WalkBack randomized controlled trial. Now, the original WalkBack findings, we should say, were already a massive success.
Yeah.
They showed that a structured walking plus education program reduced the risk of the pain coming back in the first place.
That's the main takeaway from the original study.
Hmm.
But it leaves this really critical, unanswered question, which this new analysis wanted to tackle.
Which is?
If a recurrence happens anyway, and for most people it will,
Yeah.
does the intervention make that episode shorter? Does it reduce the duration? And does it make it less severe?
Right, so if it doesn't prevent the flare-up completely, does it at least act as a kind of pain insurance?
Exactly. Does it mitigate the damage?
Make the episode shorter, maybe less painful. It's something you rarely see reported in prevention studies.
They rarely report on it because it's so much harder to track. You need really granular detail about the exact start, the severity, and the end of each pain episode as it's happening. So that's why this analysis, which looks at the characteristics of the pain event itself, is so valuable.
Okay, so let's start with who was in this study. This wasn't a group of, super fit marathon runners.
Not at all. The researchers included 596 participants for this specific analysis. These were all people who had at least one recurrence after their initial recovery.
And the demographic.
The demographic is key here. The mean age was 54, and it was predominantly female, about 82%.
Okay.
But crucially, this was a sedentary population. These are people who had recovered from low back pain, but were not currently very physically active.
So below that 150-minute weekly threshold for moderate activity.
Way below. And when you look at their baseline data, it really paints a picture of the challenge. The median time spent sitting on a weekday was 480 minutes.
8 hours.
8 hours.
Wow. That's a massive baseline of just immobility to overcome.
It is. They were really fighting a lifestyle norm. And if that wasn't enough, you have to consider their pain history. These participants reported a median of 40 previous episodes of low back pain.
40. That is a staggering number.
It is.
That tells you we're looking at a population that's kind of primed for failure, a group that has learned over and over that pain is inevitable.
Exactly. The intervention wasn't just fighting pain, it was fighting decades of habits and, fear.
Which makes a simple intervention like walking even more appealing, assuming it works.
Right.
Before we move on, we should probably clarify the definitions. What counted as a recurrence here?
So the rules were pretty strict. A recurrence had to be a new episode of low back pain lasting at least 24 hours.
Okay.
With a pain intensity of at least a 3 on that 0 to 10 scale. And for recovery, so when the pain ended, that was defined as more than 7 consecutive days with pain no greater than a 1.
Got it. They wanted to be sure it was really gone.
Yeah, ambiguity.
So let's talk about the walkback intervention itself. Given that these people were sitting 8 hours a day, had a history of 40 episodes, you can't just tell them to go for a walk.
No, that would never work. It had to be structured, it had to be personalized, and it had to be behavioral.
How was it delivered?
It was delivered over 6 months, with 6 sessions with a registered physiotherapist. And this was not your standard physical therapy.
Right, because the physio here was acting less like a fitness instructor and more like a specialized behavioral health coach.
That's the perfect way to put it. They were trained in health coaching techniques, things like motivational interviewing, setting individual goals, promoting self-efficacy, making action plans. The whole point was to empower the participant.
It sounds like they were giving the patient the tools to manage their own condition, not just the exercise itself.
Yes, they got a pedometer and a walking diary. And the education component was really aimed at reducing fear, that fear around low back pain that keeps people from moving, and encouraging them to manage minor flare-ups themselves instead of panicking.
So it's a holistic approach. You have the physical activity, which is safe and accessible, and then you have the mental framework to actually do it.
I think that's likely the core mechanism of its success. It addresses the psychological inertia that comes with chronic pain.
Then the control group.
Just a no-treatment control group. They could do whatever they wanted, but they didn't get the program.
Okay, let's get to the main event. What did this combination of walking and coaching do to the duration of that first recurrence?
The results for duration, which was the primary outcome here, were very clear and statistically robust.
So hit us with the numbers. Time to recovery.
The intervention group, the Walking Plus education group, had a median time to recovery of just 3 days.
3 days. And what about the control group?
Their median time to recovery was 4 days.
Wait, hold on. A 1-day median difference. I mean,
Yeah.
if you're a patient in agony, is 1 day really worth a 6-month structured coaching program? Where's the real value?
That is a great question, because a 1-day difference at the median can sound small, but we have to look at the statistical impact across the whole population.
Right.
This is where the hazard ratio comes in.
Okay, let's translate that jargon for everyone.
Sure. So what that hazard ratio of 1.30 means, and this was very statistically significant, is that at any given moment after the recurrence started, a person in the walking group was 30% more likely to already be recovered compared to someone in the control group.
Oh, now that reframes it completely.
Right.
It's not just a single day. It means the intervention fundamentally shifted the entire trajectory of recovery. A 30% better chance of being done with the pain at any point. That's a huge psychological win.
It is. It confirms that even if the pain comes back, the tools for getting out of it, whether that's physical resilience or just mental self-efficacy, have been improved by the program.
Okay, so a clear win on duration. Now let's dig into severity. They looked at 3 things, right? Interference with daily life, average pain, and worst pain.
Yes. And this is where the results get a lot more nuanced. It's where we have to kind of pause and think.
So not a home run across the board.
No. Starting with the first 2 measures, the study found no significant difference between the groups at all.
Okay, let's focus on that for a second. No difference in how much it interfered with daily activity.
And that's really important context. Even though they recovered faster, that initial hit of the flare-up, that moment where you realize you can't function normally, was just as disruptive for both groups.
So the program helps with the exit strategy from pain, but not necessarily the initial shock of it.
That's a great way of looking at it.
And you said no difference in the mean average pain intensity either.
Correct. The difference was negligible. The intervention group averaged a 3.64 out of 10, the control group a 3.84. Statistically, the 0.2 difference was irrelevant.
So for most of the pain episode, the average severity felt about the same.
Yes.
So we have faster recovery, but the initial burst of pain is just as disruptive, and the average intensity is the same. Was there any win on the severity side at all?
There was. There was one subtle but statistically significant win when they looked only at the worst pain intensity reported.
The peak agony moment.
Exactly.
Okay, this is where it gets interesting. Tell us about that.
The intervention group reported lower worst pain, on average, than the control group. The intervention mean was 5.48, and the control mean was 5.82.
Okay, so it's lower.
It is, and the difference was statistically significant.
What?
But we're talking about a very small reduction, just 0.34 points on that 10-point scale.
Ah, less than half a point. And this brings us right to the critical thinking part of this, doesn't it? Because statisticians love significance, but patients want clinical relevance.
That is the essential distinction here. When you put it all together, a 1-day shorter duration and a 0.34 reduction in worst pain, the study authors themselves state that while these benefits were statistically significant, they are, and I quote, small and of uncertain clinical relevance.
Unpack that for us. What does a 0.34 reduction feel like in the real world? Is this basically a win for the statisticians, or would a patient actually notice?
You know, in pain research, we often look for an improvement of at least 1 full point, maybe a 20% reduction, to say something is truly clinically meaningful. A 0.34 point drop is, well, it's like finding a penny. It's technically a win, but it doesn't fundamentally change your experience. The person in pain probably wouldn't even register that tiny drop in their peak discomfort.
That makes total sense. So if the benefits on severity are so small they might not even be felt, why is this study still so valuable?
Because we can't judge the entire WalkBack intervention just on this one secondary analysis.
Right, you have to connect it back to the original trial's findings.
Exactly. Those do have massive clinical relevance. The true value is in prevention. This is just sort of the bonus data.
Okay, so the main message is still the original one. Remind us what that was.
The primary value of the WalkBack program is that it prevents recurrence in the first place. It reduced the risk of any recurrence, and more importantly, it reduced the risk of an activity-limiting recurrence, the kind that really disrupts your life. And it was cost-effective.
So that's the real prize. The program makes it much less likely you'll get pain again, and if you do, you also get this small bonus. It'll probably be over a day sooner, and your worst moment might be a tiny bit less awful.
That's the most balanced summary. We knew from other studies that exercise and advice might reduce pain at, say, 12 months out. But this study is great because it looked at the event itself, the recurrence as it occurred. It tells us the benefits are immediate.
Okay, let's talk limitations. The researchers only looked at the first reported recurrence. Why stop there?
That's a great point. Low back pain is messy. If someone hasn't fully recovered from their first episode, they aren't technically at risk of a second one yet, right?
Sure.
So looking at later recurrences gets really complicated and could skew the results. They needed a clean slate for each data point, and the first recurrence gives you the cleanest data.
And I imagine, like with any study about pain, self-reporting is always a challenge.
Absolutely. It all relies on participants remembering their pain intensity and recovery dates. There's always a risk of recall bias, even though they tried to minimize it with monthly data collection. It's just hard to remember precisely what your worst pain was 3 weeks ago.
So bringing it all together for you, the listener, we have a program of walking plus coaching that radically reduces your risk of future pain. And if that pain does come back, the episode is statistically a day shorter, with a slight but maybe not noticeable reduction in the very worst moments.
That's a perfect summary of the findings.
Mm-hmm.
The core implication is still that this program is highly effective for prevention. The other benefits just sweeten the deal.
It makes a really compelling case for walking as long as it's paired with that critical coaching piece. Okay, let's wrap up with a final thought for you to chew on, one that builds on the mechanisms we talked about earlier.
We established that the intervention wasn't just physical. It included that individualized health coaching, right? To reduce fear, to encourage self-management, to build self-efficacy. So, given that the measurable physical benefit in severity was so minuscule, that 0.34 reduction, we have to ask, does the psychological benefit maybe outweigh the small physical changes?
That's a powerful point. You're saying the biggest win might be in the patient's confidence?
Maybe.
If they feel 30% more likely to recover faster, even if that's just 1 day sooner, that confidence totally changes their relationship with pain.
It does. When you're dealing with a condition as recurrent as low back pain, how do we measure the true value of an intervention? Maybe the greatest value isn't shifting the pain scale by half a point, but in teaching people they have control over their recovery, empowering them to move, changing the narrative from "I am broken" to "I know how to manage this."
That shift in self-efficacy is a huge win, even if it's hard to put a number on.
A tremendous win.
That is something truly worth mulling over, the power of confidence in fighting physical pain. Thank you for guiding us through this incredibly deep dive.
My pleasure.
And thank you for joining us. We'll catch you next time.